Hello, my name is Jung Ho Kim from Yonsei University College of Medicine, South Korea. Today, I will present a study called Patterns and Prognosis of Holding Regimens for People Living with HIV in Asian Countries, conducted through data from Taehood and Taehood Right. First, the background. There are no universal criteria for treating people living with HIV who have experienced multiple treatment failures. In this case, providers may choose to maintain patients on holding regimens in anticipation of future treatment. The use of holding regimens can have effects on outcomes such as survival and CD4 cell count, and it also can have effects on drug resistance which affects future treatment options. Therefore, we aimed to investigate the patterns and their prognosis of holding regimens for people living with HIV in Asian countries. Now we move on to the methods. This study included data from adults enrolled in the Taehood and Taehood Right. Data from Taehood were included up to September 2018, while data from Taehood Right were included from the most recent 2017 data transfer. How to define the holding regimen was one of the most important issues. In this study, individuals were considered to be on holding regimen if they had been on combination antiretroviral therapy for at least 6 months, had 2 compound viral load more than 1000 copies per milliliter, and had remained on the same medication for at least 6 months. The primary outcome was to identify the patterns of holding regimen as previously defined. The secondary outcome was to assess the survival time and factors associated with CD4 changes and viral load. Let me tell you about the result. First, you can see the patterns of holding regimens by World Bank country income level. For low-middle income countries, NNRTI-based regimens were mainly used, and the combination of lamivudine, zidovudine, and nevirapine was the most popular regimen, followed by lamivudine, zidovudine, and efavirenz. For upper-middle income countries, still NNRTI-based regimens were mainly used, and the combination of lamivudine, zidovudine, and efavirenz was the most popular regimen, followed by didanosine, stavudine, and efavirenz. On the other hand, for high-income countries, PI-based regimens were most commonly used, of which a regimen consisted of lamivudine, tenofovir, and ritonavir-boosted atazanavir was the most popular regimen. Now, you can see the factors associated with mortality of patients on holding regimens. Overall, 41 people living with HIV died during the follow-up period while on holding regimens. The mortality rate was 2.0 per 100 person-years. In multivariate analysis, factors associated with increased mortality were ages over 50 years compared to ages 31 to 40 years, and viral load of more than 1000 copies per milliliter compared to viral load under 1000 copies per milliliter. On the other hand, higher CD4 cell count had protective effects against mortality. So, summarizing the result of this study. In our Asia regional cohort, there was a diversity of holding regimens, and the patterns differed by country income levels. In lower middle and upper middle income countries, NNRTI-based regimens were most commonly used, but PI-based regimens were commonly used in high-income countries. The mortality rate of people living with HIV with holding regimens was more than twice than that of other people living with HIV in our cohort. Considering the high mortality rate of people living with HIV with holding regimen, efforts to extend accessibility to additional antiretroviral options are needed in our region. I sincerely appreciate writing committee members, especially Junyoung Choi. I would also like to thank steering committee members who advised the study, Taehood staff, and all the other study members of IEDA Asia Pacific. Thank you very much.